So Michelle is the professor and chair, as well as clinical chief of family medicine at Georgetown University. She's the founding director of the Georgetown University Center for Health Equity, which is a newer role relative to her chair role in family medicine. She also is the director of the DC AHEC, the Area Health Education Center. She's the co-medical director of health outreach for the Hoya Clinic, which is the health outreach for youth and adults clinic, which she may talk some about. It sounds like a pretty fascinating effort, engaging students and faculty. She's a former residency director in family medicine at Georgetown. And she is a lifer at Georgetown. She got her her MD degree at Georgetown University School of Medicine, did her residency there, and also a community health fellowship in the context of her training. She has research and practice interests in racial justice, care of marginalized groups, community partnerships and engagement, efforts to eliminate health disparities and advance health equity. So without further ado, I introduce Dr. Michelle Roett.
Thanks so much, Dr. Shipman. Can you hear me okay? All right, just starting my timer. So I really appreciate this invitation. I just want to say thank you for showing up in person, and thanks to everybody on Zoom, although we can't see you and we know you're there. I'd like to thank the Dean for being here as well, Dean Dunley. And in general, I tend to say no when I'm invited to these occasions because I'm not, enthused about public speaking. But I enjoy the experience and love to come visit and hear about the experiences in other institutions. So I often end up saying yes anyway. So really especially thankful for Scott to think of me and to invite me. So really grateful to be here. I'd also like to give a shout out, I don't know where he is, Dr. Goodman, where did you disappear to? Family medicine, family and community medicine, have to say hello. Was reading about the great work about the rural health track, and we just talked about street medicine and reading about the lifestyle medicine work. So pleasure to meet you in person. So I have a few disclosures, but these are about my federal funding, thankfully. This is funding from HRSA and funding from the NIH around AHEC, and a more recent award we just got a couple weeks ago from NIMHD for a Center of Excellence to fund work in this community engagement space for early career faculty. So the objectives you've seen, so I won't recap. We're going to talk about meaningful community engagement. We're going to do a little bit of a deep dive into how do we assess that, the metrics, what would you like to do as a School of Medicine to really assess yourselves to see how well you're doing. Let's talk a little bit about the challenges that we might face in that space as educators, researchers, clinicians, everyone who works with learners. And then some of the effective interventions out there that other schools have tried around teaching in this space and having meaningful community engagement for students. So I like to ground my discussion a little bit in something you've probably seen many times over, but really like to talk about this when I talk to students, especially about the health disparity space and advancing health equity. So at a convention of the Medical Committee for Human Rights held in Chicago in March 1966, the Reverend Dr. Martin Luther King Jr. spoke very eloquently about health justice and health equity, although it wasn't in those terms back then. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman. This image is from 1966. It's not from the convention. That is Lyndon Johnson's hand in the background. He's sitting next to the president. I really just wanted to ground us here to say that we've been dealing with some of these disparities for beyond decades, and some haven't changed. We've got more skills and more resources and more people dedicated in this space, but the outcomes for some groups have not changed. So just want to come back to that a few times today. And today we're going to be primarily discussing the educational space. I sit in several different mission areas: education, research, the clinical space, and service. We'll be mostly in the education space, but I just want to acknowledge, different roles in the room. Any students here? Residents? Okay, faculty. Okay, any institutional leadership, chairs, deans, PIs? Okay, any CEOs or CMOs of health systems? Okay, some hands were raised. Okay, so we have a good mix. So I do feel like much of what we're going to discuss is going to touch on everything and all that you see in your world. So this is an image I'm sure you've seen. I've seen this in many different presentations, and I keep going back to it because we often equate equity and advancing health equity with an access issue. We talk about this in the context of giving people different resources and access to resources. If we have more resources, we could do more. If we have resources that are plentiful, we can't always do everything for everybody, though. So it doesn't always result in equitable access. So providing equitable access, for example, is not just providing equal resources, but recognizing what are the existing resources that we have, what needs to be adapted, how do we adapt it to our communities and their needs, and what are the specific barriers? I mean, there's a really obvious systemic barrier here that we could just remove the fence and not have to give anybody any of these boxes. So thinking about what the structural pieces are and the systemic pieces needs to be part of our thinking, and just wanted to not oversimplify that conversation about equity versus equality. And then in reality, most of us look at this other image and we think about another space. So to put it another way, advancing health equity necessitates consideration of many, many factors. Meeting patients and communities where they are, that's certainly what we're trying to do. We need to think about the social determinants, the distance traveled, all of the different barriers, adverse childhood experiences, all of the things that we know now could get in the way of a healthy outcome, all the policy decisions. But we do have to think about the positions of power and privilege that perhaps might give a higher advantage or a significant systemic disadvantage to different populations. So this is why I often use this, often with our pathway students, to really illustrate, the position of power and privilege. And I'll just stop for a moment to say something about my own place of privilege. As a physician, I've got access. I've got access to resources, physicians, but my mother was diagnosed with breast cancer about 7 years ago. She recently passed away, but when she was first diagnosed, it was really difficult to navigate that journey. She didn't know what she was going to do. She literally was thinking she's just not going to receive care, and so let's just deal with it. And finding somebody who would see her with her insurance, where could she get her treatment, her surgery, who's going to do the surgery. She had great care at Lombardi Cancer Center at MedStar Georgetown eventually, but the journey to get there was really difficult. And then, where's she going to get radiation, and the doctor's office where she went to talk about chemotherapy. She ended up coming out saying, well, I don't think I'm going to do that. I'm not going to do chemo. I think that's it for me. And I was just left thinking, well, how did that conversation go? Was it optional chemotherapy? Was it, did you talk about what the consequences of that decision might be? Was it that you were not in the risk category, that you absolutely needed chemotherapy? I just had no way of knowing that. So I called up the doctor to ask those questions. But, the circumstances are not like that for most of our patients. We can't just call up the doctor to ask. But her cancer was in remission when she passed away from something else. But just wanted to say that's the place of privilege that we come from. Okay, and then I know I'm probably preaching to the choir here, but must start by just talking about how I'm going to be defining these terms. Population health in a health system, we're usually talking about it on our health system side in terms of the communities we serve or the patients that we see in our health system. So that's not a typical definition, though, in the public health space. We're usually talking about the distribution of outcomes in these groups. Social determinants, well established, we don't need to define that. I just want to say a bit about healthcare disparities in terms of differences in the quality of healthcare, not necessarily about access. And then the health equity space, we're talking about more systematic, avoidable, and unjust spaces. So removing the fence. or making sure that we're talking about things in a structural way. And then the NIH defines health disparity populations very specifically too. I do feel like this has evolved tremendously over the years to include more groups that are traditionally marginalized. So now in terms of disability, for example, and LGBTQIA plus populations. So it's much more specific to groups that have specific disadvantages. So it's a very broad definition. So examples of health inequities. We're going to do this briefly. Hey, Wada. One of the pieces of the puzzle that we always talk about are, which health inequities are being addressed in each community, or which ones are more evident in a community. These just happen to be examples that in almost every state, every city, every area, that you can find some evidence of inequities in these spaces. So breast cancer, for example, is still the second leading cause of death among women in the US. It still has the highest breast cancer mortality is in Black women compared to other women. Same in many of these other areas, particularly for colon cancer in African-American men. We could say the same for prostate cancer. Diabetes-related deaths and cardiovascular disease, all of these, they all have examples. Maternal mortality is much more in the public sphere today because of where we are with reproductive health and women's health, but also because of preventable morbidity and mortality and preventable death. Something that we need to talk about. Babies born to mothers, for example, who don't access prenatal care or don't have access to prenatal care are much more likely to be preterm, low birth weight, much more likely to have higher infant mortality. These are just preventable spaces that we could be contributing to. We're going to talk a little bit about some of these, not all of them, but just wanted to illustrate. Are any of these things that you did not know were in the health equity space? Everybody's heard of all of them. Okay, good. All right, so why do they matter? Again, these are things I know this audience knows, so we won't belabor the point, but they're associated with worse health outcomes. That's why we're here. This is why we do what we do, why we teach, and why we're in this space. But one of the things that we need to remember is health disparities don't just affect the people in the disparity groups, they affect everybody, because now the resources are going to be limited. Everybody's not going to be able to get an appointment or access care. And then the quality of care declines when there are high disparities in the space. So being able to address these disparities for one community could affect everyone and improve the health outcomes for everybody. So it's becoming much more urgent too, because of course it's preventable morbidity and mortality that we're talking about, but the population is also becoming much more diverse. So we would expect that these disparities are going to become much more prominent. So we've got to galvanize ourselves a little bit. So I know that in this space, CMS has driven us in the health system to be much more cognizant of where disparities are, implementing our screening for social determinants, looking at health inequities, and applying metrics in our clinical side. But the fundamental reason is it's preventable morbidity and mortality. So switching gears to what is known to reduce health disparities. So of course, as a family doc, I would be remiss if I don't talk about primary care a little bit in these conversations. So there are many things we could do, many actions a health system could take to reduce health disparities. So this is not the only one, but the one thing that we know that has been known to reduce health disparities is having a functional primary care system. So this is the only specialty that if you have more family docs, you're going to have better outcomes and more equitable outcomes. But it's true not just for family docs, the entire primary care specialty group. So if it's high functioning, it's even better, much more equitable, much better outcomes if it's a high functioning system. And what's that? What is a high functioning primary care system? So the National Academies of Medicine got together, of course, around what that might be and defined it. And if you haven't seen that report, I encourage you to look at it. But better prevention, screening, monitoring, care coordination, all the interprofessional teams that we've been teaching students that are valuable These elements all contribute to decreased disparities in these patient populations. So integrated care, whole person care, continuity of care, patient-centered care, all results in improved outcomes. Why? Because now we're detecting breast cancer earlier. There's fewer deaths due to heart disease, fewer cases of lung disease and colon cancer because you're detecting earlier and removing the polyps. Cervical cancer is a lower incidence as well. And of course, lower healthcare costs because of the less emergency medicine visits and less hospitalizations. We're going to come back to that. I just wanted to mention that up front. And one more slide about showing you what we're talking about. And this is from the Kaiser Family Foundation, and I often use this too in some of my discussions with both health system leadership and with our students and residents in talking about all the factors that contribute. So we talked about what could reduce it, what it's defined by, the factors contributing to it. Some of these are obvious that we talk about all the time. If somebody has inequitable access to care, especially primary care, these social disparities, mental health, economic disparities, all of these would be much more prevalent. But in general, high quality primary care could have reduced all of the disparities that we suddenly opened our eyes to after the COVID-19 pandemic. But that wasn't a time where we suddenly had more primary care access. We had less. So I'm sure we all felt it too. If we needed to see our primary care doctor, we couldn't after the pandemic. It was really difficult. So there's increased recognition that improving health and achieving health equity means that we have to look broader than that. It's not just about access and not just about the health system. We have to look at the environment, the resources. We've got to look, I mean, amazing that we're just coming to these conclusions that we need to look at all these things. Back to Reverend Dr. Martin Luther King Jr. In 1961, he talked about these very things. This is a slide from 2018 from the Kaiser Family Foundation. But in 1961, he wrote in The Nation, in an article entitled "Equality Now, the President Has the Power," he called attention primarily to considerable amount of discrimination. You know, it was a feature of the time, of course. But he was talking about health and hospitalizations. And he specifically spoke about federal funding, federal government granted funds to states for the construction of hospitals for mental health, maternal health, and childcare, and for programs designed to control cancer and heart disease. That sounds familiar, doesn't it? And about the primarily Black people, and of course, those are not the words that he used, but primarily Black people denied access to these programs and services. And Dr. King called attention to the problem of housing discrimination and suggested changes in federal housing policy to specifically affect health outcomes. He talked about discrimination in housing, segregation, and federal housing policy. And again, housing policy, housing insecurity is still here as one of the factors contributing to health disparities and inequities. And this was from 1961. So it still feels like there's a lot of work to do. We don't have the overt segregation that we had in those times. This is not the time we live in today. But we still have housing discrimination. I can't tell you, I won't use the time to tell you all the stories of my patients because I don't want to misappropriate their stories. But I do feel as though the things that I'm hearing today are the things that I read when I studied my master's in public health that happened decades ago, and they're still happening in our communities. So it can be extremely, not for want of a better word, just depressing to think about that we're still in this situation, that there's so many that don't have access to safe housing, that I still need to call a medical legal partnership consult or a colleague to help me navigate a situation with my patient because her daughter has asthma and the landlord is refusing to exterminate the cockroaches, or that there's mold and mildew and that there's not been a remediation of it, and that her daughter's been in the hospital multiple times. These are still the scenarios that we're living in and that our patients are experiencing. So to jump a little bit forward to the community engagement part of the conversation, that community and social context is what all this introduction was all about, was to get here. Was about the social integration, the support systems. How do we account for the negative effects of that discrimination and stress, maternal stress, parental stress, toxic stress, all the different stressors that somebody might have, and how do we incorporate community engagement into what we do in a way that helps health outcomes. So let's talk about that. So community engagement, NIH has a definition, CDC has a definition. I'm not going to belabor the point about how they define it, but I'm just going to point out that the key is collaboration with the community and not talking to the community about what you want to do. So I'm sure everyone here knows this and has done this before. One of the places that we often fall short is how do we incorporate the community into everything that we do? So working collaboratively is not just showing up, it is planning together, co-creating, co-presenting, co-designing. A research project is co-designed, the study is designed together, the policies and programs and practices that you are engaging in are co-designed with your community partners. And the CDC goes a little bit further by saying that these collaborative groups should be engaged or might be engaged in health promotion, research, and policy. We're going to come back to the health promotion, research, and policy a couple of times, but that to me is the intersection with medical education and where we can incorporate some of these principles. So when I started my work with DC AHEC, I did my community health fellowship. I was working in an FQHC. I started working at Georgetown as faculty, and I started to be called on for community engagement. So Michelle, could you help us, because we don't have a community partnership with any of the FQHCs? What could we do about that? So in my mind, well, we can't just show up with 200 learners because we have 200 students per class. We've got to build relationships, figure out how to work together. You're laughing because you were there at the beginning of our community-based learning opportunity. It started as an optional elective for students to do. Now it's a required course for all 200 students to work with our community partners longitudinally. Started out as a 2-year course, now is a 10-month course across a year and a half. But in general, these types of courses need to have guiding principles to be successful, because we'll talk a little bit about the different gradations and discussions of how you can approach this. But if we're using a health equity lens to approach it, considering the key principles like person first language, using preferred terms, engaging with the community partner as a partner in this relationship and not somebody who's doing a service for us, but that we're doing a service for them. And then using some of the resources that are available to you, because the health system has a community health needs assessment, the state usually has a needs assessment, there's a primary care scorecard available to you, there's workforce data. You can come equipped with all of this information to your community partner to start talking about how you could be helpful when they are coming to you and identifying needs, how you could potentially serve those needs. I'll come back to that. The diversity, equity, and inclusion competencies across the learning continuum was from the AAMC Center for Health Justice. Really extremely helpful document to us at Georgetown University when we were coming up with our health equity competencies, because they really outlined exactly what we would want a learner to achieve once they were practice as a practicing clinician. What would be like them to experience as a learner that allows them to develop the skills to be that person out in practice who wants to serve an underserved community. All of these other publications, I feel, have been extremely helpful to us in crafting our vision for what we wanted to do and then guiding us along the way with our strategic vision. Another space that we used quite a bit of the resources of the national academies had an organizing committee around assessing meaningful community engagement, and gave us a little bit of a framework to look at it. And the only thing I wanted to say here, we'll come back to it in another context, is community engagement is the center here, not the learner, not the school, not the institution, it's the community engagement. So that means we're not looking at it from our mission of research, education, clinical service. We're looking at it from a community-centered approach of co-creating, we're co-equal, we're building trust. It's a bi-directional relationship, and that the community is at the center. You got to define what that community is and which community you're working with, but the community is at the center. So let's talk about metrics, about how you would be able to assess some of these things, and I'll do a deeper dive into some of the things that are depicted here. So I just talked about competencies. I'm going to walk around if that's okay. Yeah. So competencies are something we like to assess ourselves. We like to know that we're performing well compared to other institutions. We like to know that we are able to improve each year. So setting goals and looking at the competencies that you want your learners to achieve could be a good place to start if you're just starting a new project. So this is just an example. These are competencies taken from that competency document I just talked about from the Center for Health Justice, from the AAMC. So let's say you have a student who wants to volunteer to do something. We'll talk about that in a second. But a medical school graduate, you want the medical school graduate to have identity formation in this space, to have knowledge, to value the interprofessional role, to identify systems of power and privilege. You want the medical student to have a foundation. You'd like the residency graduate to have a little bit more than that, to have more knowledge, to be able to apply it, to be able to address some of it, to be able to assess for social determinants of health, to be able to work collaboratively with teams to address barriers. But you'd like that resident to, be a part of a collaborative care structure. But you'd like a practicing clinician to do more. You'd want them to role model service in their life. You want them to have a career that has service be a part of that, and for students to see it and see it be successful. You want them to lead a team. You want them to be able to teach effective strategies about mitigating biases, teach about health disparities too, social determinants of health, teach how systems inform policies and practices. This is just one set of competencies. I like this document really a lot because when we were adapting it to our setting, it really helped people see we're not achieving this in what we're doing. If we're doing the basics, and here's the basics. So if a medical student wants to volunteer, for example, at a student group health fair, at a community center for area exposure, that's wonderful. We'd never discourage that. We'd love to have students volunteer. We'd love them to collaborate with a community partner. It's on the spectrum of, in the beginning of community engagement, is volunteerism. So volunteerism is good, but we would really want to encourage that student to move along that spectrum from volunteerism. We'd like them to collaborate with the community partner on what the community partner's needs are, not just show up to volunteer for that hour, but think about what could I do over the long term to be really helpful to this community partner so that I could affect my community's outcomes. So ultimately, that's what you want the learner to walk away with. And then you really want that community engagement to result in longitudinal collaboration. So if there was a coalition of academic community partners that set priorities, there was longitudinal collaboration using best practices and evidence-based approaches, then you know that the plans that you've made are all related to improving health outcomes, and potentially you could make an impact with the projects that you've chosen. You don't necessarily know that for each project that gets proposed that is around volunteering for a few hours, if everybody's with me. So I think all of us have been on this spectrum of volunteering, helping out, being there, showing up. All of this is good. So not discouraging it at all. There's a spectrum, and we need to be able to show in our competencies that we're progressing and that we have a goal set for our learners. So we could go a little bit further in this competency assessment and look at actual data. So every school gets the mission management tool report from the AAMC. Has anybody seen that in the room? No, you have. Okay. So the mission management tool gives you an assessment of your school compared to other schools. So what percentile are you in compared to other schools? So in general, many schools like Creighton, like Georgetown, are really high in these categories. Georgetown happens to be exceptionally high in these categories. So field experience in community health, experience related. So these are the students answering these questions as fourth-year medical students, that they got great experience, they've got knowledge about cultural awareness and experience in that space, and they're prepared to care for patients from different backgrounds. So fundamentally, this is a minimum that you'd like to see, is that you're performing really well in this space. But there's some other metrics that could tell you a little bit more about whether it's meaningful what they're doing. So let's say you're in the 90th percentile for these. There's a couple more questions that you want to ask of yourself. How is your institution doing compared to others in terms of key measures on advancing health equity? And these are the key measures. Are your students planning to care for the underserved? So that's just a question that the students are answering. And for most schools that score in that 90th percentile, they're scoring, what if you score below the 25th percentile in whether your students are planning to care for the underserved? Really, really hard to be in that under the 25th percentile, because on average, most medical students are not choosing to care for the underserved. About 34% of students in most longitudinal surveys are answering that they are planning to care for the underserved. So if you're in the 25th percentile, then probably this is about less than 5% of your class is saying that they're planning to care for the underserved. Practicing in an underserved area is not a fourth-year metric. It's people actually where they're practicing. They're looking at the AMA physician master file, and they're giving you a report back about if your former students are now practicing in an underserved area. So if you're in the 25th percentile there, you can't control what the student does, 10 years after they graduate, but this is a metric to show whether or not they keep that commitment. Are they practicing in state? Are they practicing in rural areas? All of these are critical to be able to say this as an institution that we're doing really well in this space of meaningful engagement, because my students are doing what we need in my state. And same with practicing primary care. It's a proxy because, of course, we want students to do every specialty, but we still want students to choose primary care so that it's adequate for the community. Okay, so let's say we've done that. We've looked at our metrics. We've set goals around our metrics. How do we predict if a student is going to be committed to serving the underserved? What is the most evidence-based way to demonstrate that a student is going to serve the underserved? And these are some obvious things, I think, and some not so obvious things, but if a student has more community-based experiences, particularly community-based learning, which is more longitudinal, it's not volunteerism, it's community partnership, is about in the middle of that spectrum that we just talked about, they're much more likely to choose a career working with underserved populations. Same with the curriculum focus on health disparities. And where did this come from? This comes from surveys of students. So this particular data comes from two pretty large studies, one with 1,000 students, one with 4,000 students from 49 medical schools. So the one with 1,000 students talked about surveys of students in third year and then in the beginning of fourth year after they had applied to residency programs. So hopefully they were truthful about where they were applying to, but students said the experiences that they had that were linked with their choices, and then they looked back at how they answered the survey as third years, and that's what we came up with. So the work experience in a religiously affiliated organization and a very strong sense of calling were also both very highly correlated with choosing to work with the underserved. Growing up in a medically underserved community, medical school mission score, we're going to talk about social mission score in a second, and talk about the social mission metrics. The factors decreasing student commitment to working with the underserved, that was well established in another study, the one with the almost 4,000 students. It depends on how well diversity and health disparities and racism were addressed in the curriculum. So if the curricula were particularly negative or did not address anti-racism, then, and back then we didn't use that term, anti-racism, but if the school curriculum didn't represent that well, then those students were less likely to choose working with underserved communities. So in general, If the students perceived that they had a skill set with developing relationships with underrepresented populations, both in their patients and in their peers, so they had diverse classmates and they had experiences working in communities that were diverse, then they were much more likely to choose working with underserved communities. And a lot of that was about confidence and feeling like they had the experience. If they felt like they had the courses, the teaching, the culture, climate were not in that space, then they were less likely. I think that makes sense. The social mission metrics, all of this fed into. There's some really wonderful publications around this and good work being done by the Social Mission Alliance at George Washington University by Fitzhugh Mullen. And if you haven't looked at this at all, you should. But the social mission score, I do remember the first time that we talked about this as an institution, everybody was really concerned about the social mission scores being published and that a school like ours was scoring really low in the social mission score, even though that was our mission, vision, values. This is who we are. How come we're scoring poorly? Well, that was because the curriculum was not matching what we were doing or what we were saying. And then the community collaboration wasn't there. The curriculum was not aligning to the community's needs. Student diversity was very low. Faculty diversity was low. All these metrics were not coming together for a high social mission score. So these are all the metrics. If you haven't seen them, I would spend some time in them. It's about pipeline and pathway programs are there. How much time are you spending training your faculty, the leadership, diversity, all the things that you would think. And this was published in 2020, but the social mission score development was years before that, just pulling together all the literature in this space. And then where does Creighton rank? So this was hard to find. I don't have access to any of your AAMC data. I don't have access to your mission management tool, and I didn't ask, so I don't want to put anybody on the spot. But I could find the US News rankings, which is what your applicants would see if they're Googling the school and they're thinking about coming to Creighton. So a lot of schools backed out of US News rankings in the last year or two or years before that because some of the rankings were just not accurate. They're not depicting what you actually do. This is the 2024 ranking. And this is new because US News started collaborating with the Robert Graham Center for Policy Studies, full disclosure, part of my department, but they're under the American Academy of Family Physicians. This is the health policy think tank that publishes around primary care workforce and has been for the last several decades. So now the data is real data in US News, and this is where Creighton ranks. Any surprises? So about in the middle or just over the 50th percentile for practicing in rural areas, over the 50th percentile of the other medical schools for practicing in primary care. These are pretty good numbers. A little bit lower in the percentile space in terms of graduates practicing in health professional shortage areas. That's our proxy for practicing in underserved areas. So a little bit lower in that spectrum. Is that surprising there? Based on the social mission of the school? You'd want that to be higher. Yeah. And then unranked, because this is for not participating, and this is not unusual because many schools didn't participate in the self-study metrics for primary care and research, so there's no ranking for that. But these are all the proxies. So something to think about. I'm not one to encourage people to use US News and World Report for any rankings. I would not do that. But it is an interesting space to explore again now that the Robert Graham Center is back in that space to encourage some accuracy. So a couple other strategies to think about, and this came from the Center for Health Justice from the AAMC, promising strategies for addressing health disparities. If you find that you're in that space, you have a specific mission, vision, values that you want to live and breathe, and you would like your graduates to experience, these are some ways that you could approach your strategic planning, your visioning, or what you're going to do next. Leverage that, enthusiasm of the learners to be out there in the community to ensure that you're addressing social determinants of health, that you're addressing health outcomes, but also critically examine how you're doing research. Is it what we like to call in our Center for Health Disparities research, tier 3 research that is about improving health outcomes, or is it about establishing the status quo? Is it about repeating reproducible numbers each time, or is it about helping what the community is asking you to help them with? Making sure that you've got experiential learning, community-based learning. We talked about that as a successful space. All right, so back to this. So I believe because we've talked about the community-based learning, the social mission, that we've touched a little bit on several of these spaces. So I'm not going to jump into each and every one. I'll talk a little bit about each. The expanded knowledge piece, I think, is the most important to give an example. But the competencies and metrics we already said, using that health equity lens. What we ended up doing in 2020 at our institution was reproducing some of the studies that had been done at Brown, I think was the first place that did it really well, looking at how bias was depicted in our slides that we teach our medical students. Are we using appropriate images? Are we using cases where we, talk about marginalized groups in negative ways? How are we talking about race as a social construct, or are we using it in the context of a biological construct, which it is not? Are we using diverse skin tones when we're teaching dermatology? Literally just a playbook of how you could look at your curriculum. There's several checklists that were developed, one at SUNY Downstate that we adopted for our institution as well. All of these are effective. They really are demonstrating how much you could change structure and how much you could change students' perceptions by implementing small things. So we reproduced one of these studies at our institution, just to give you an example. So medical students over the course of time have always believed that Black and Brown patients have a higher pain threshold. Why would a medical student believe that? A first-year medical student. Why would a first-year medical student think that? Where would they get that from? Sorry? Yeah, maybe old material, could be getting it from their books. Who knows where they're getting it from, or they could have been getting it from other experiences. A lot of medical students have legacy families where, who knows where they could have heard that. But they come in with the same myths. Residents have it too. So do faculty. And so implementing a new curriculum and looking at bias in our slides, reforming, having faculty training, teaching about race and medicine and some of the history of race and medicine, and then looking at this again a year or two later showed that statistically significant differences in how our students are coming to the table with their beliefs. So now we do an orientation. We use Dorothy Roberts' reading, Fatal Invention, from University of Washington at St. Louis uses that method. If you look at what's out there and what other institutions are using and have been successful using, you can find tools to help you in this space. Same for the strengthened partnerships. This is another example. If you're able to have a strong partnership and alliance with your community partner where trust is at the center, then you could design really effective programs together. So partnerships with programs helped us to come up with a community health worker program and design a navigator program where now our students who volunteer for our student-run free clinic are trained as navigators. So we have a refugee navigator program, a street medicine navigator program. We were just talking about street medicine before we started. We have a navigator program for our chronic disease specific quality improvement. And then we have a wound clinic navigator program that the students came up with based on patients asking for help in the wound clinic. So community health worker interventions and planning that helped us to see that, oh my gosh, the students are doing this too. It's not just that we need more community health workers, but if the students are in the space, they need the training. So now we have a pretty extensive navigator training for them. And there are some schools that implement health coaching training, navigator training into their curricula. All right, last couple of slides. So the structural support for community engagement as an institution, I'd really like you to think about, what do you currently have in place to make sure that this could be sustainable? One of the things that the AAMC suggests is using their new health equity inventory. Has anybody seen it yet? It's been in development for many years, so it's not brand new, but they're only now asking people to participate. So it's intended for you as an institution to work with your community partner to log all of the health equity focused projects on your campus and your institution. It's in one place, all the research, the community service, the clinical projects, all the educational programs, so that your community partner knows all the work that you're doing and that you know all the work everybody else is doing, because we're always stepping on each other's toes, reproducing other things and not necessarily working together when we're in big institutions. But the health equity inventory is a really nice structure that I think people can get behind. And then, of course, we talked about the navigator programs already. I really just wanted to make a point about the health system focus on health equity here, but I think we've already talked about this, so I'll just go to the community aligned solutions. So in general, be intentional about the choices that you make. You want things to be co-developed with the partner, co-curated, co-produced. 30 years ago, the public health community was really completely taken aback by communities saying that they had no idea that the co-created pieces that we thought were happening didn't result in the community partner being on that publication or presentation or being a part of disseminating the results. Why not? We would like our community partners to disseminate the results to help us with the next project too. So they should be a part of every phase. And then the last part that I'll say, and then I'll try to leave some time for some questions, is making sure that the outcomes of your community are the outcomes that they are interested in, not the ones you're interested in. Not because I love to work with on diabetes, I can't just choose that I'm just going to do a diabetes project. Everybody's doing my project in my diabetes space. It needs to be about what the community partners tell you. And one of my colleagues, Dr. Janine Reffi, in Community Peds, who now runs the Kids Mobile Medical Clinic, our Ronald McDonald van that we had years ago, worked with a community partner to identify food insecurity at the beginning of the pandemic as a major maternal stress for new moms and for families. And so designed a meal and grocery delivery service for these families and was able to show over the course of time, and now it's a much bigger project than the 40 families I think that she started with. Now it's hundreds of families getting meal delivery services and grocery deliveries, but was just able to show decreased stress in the parent-child system. And at that time, that increased stress was also associated with developmental delay and adverse childhood experiences. And so what a major impact you could have by choosing to work with a community partner on what they want to work on. Okay. So I'm going to skip this and go straight to the take-home points. I feel like we've talked about everything we wanted to talk about, or at least everything that was on my list. But I'm hoping that you're walking away remembering, co-creating, co-planning with a community partner, collaborating with the community partner on everything from strategic planning to the health promotion, research, policy making, to your mission, your education mission, your research mission, your clinical mission, your service mission, that the community partner is a part of it. And that there's some structural support for that sustainable community engagement because you want to keep it going. But that you're also tracking and thinking about, how am I going to measure my performance? How did I do? Did I do well? Are students choosing these careers? Because to me, that's the ultimate measure, is if we're doing this really successfully, there's improved health outcomes in the communities that we're serving, but also the students are choosing to do these careers. So tracking that, tracking it through your mission management tool, tracking your GQ, and tracking your social mission metrics, but also looking at population. So I've included my references so that this could be circulated with you, but I really wanted to leave some time for questions. I'll just say thank you for having me again. Thank you for allowing me to speak about this space and about meaningful community engagement. I appreciate your time.
So for the benefit of, excuse me, for the benefit of the folks on Zoom, I'll run mic around the room for folks. And for those who are on Zoom, feel free to type in your questions, and we're keeping an eye out for those.
I'm looking for some, I don't know, some wisdom from you for my completely unfounded assertion that one of the ways in which we could encourage students more readily to say, yes, I plan to work with underserved students, is to help them come to a sense that without working with underserved students, their lives are diminished. In other words, to engage in some really serious reflection about the gifts that others give to them in those encounters and how those complete their humanity in a way that isn't going to happen somewhere else. And so in some fashion, I want to call it a hunger for my greater fullness of humanity, which is a gift I cannot give myself, can't find any place else. It's a gift that comes with attentiveness to uh, folks who are most in need and can't in some fashion repay me, but actually give me more than I can imagine. But I mean, do you think that's naive? Do you think it's unrealistic to engage in that level of reflection during training?
No, I think that's exactly a way to do it. I think you said it well. It's not an easy thing to implement or an easy thing to ask because most of us are a little bit afraid of what the results might show. That students might say, no, I don't want to do this, or I'm not interested. But, students are like us. We were in their shoes at one point, and they decided to do this profession because they wanted to help others. And to be honest, it's a little bit our fault how jaded they become by the time they graduate. We've all seen the data around social empathy and the nosedive that it takes for medical students, typically between second and third year. Third year, it just takes a nosedive. Why does that happen? That's not because somehow third year there's a switch. It's because they're spending more time with us. And we're the people who are influencing them. So if by chance, as a first or second year medical student, that you were reinvigorated in this space because you had more exposure and experience with longitudinal community partnerships, perhaps, and that is in the literature too, your social empathy doesn't take that nosedive in third year. So I would say, I would challenge that if that is something that you're willing to champion, that you should engage in it, because that reflection exercise could be the difference between a student understanding that this is my calling versus, that jaded transition happening as a third year medical student.
So I want to thank you for pointing out our extraordinarily, embarrassingly low number of students that go into areas where they're most needed. And we've agonized over this. I will tell you that our efforts in diversity and some other parts of the medical school has been a total rebuild over the last 5-6 years. We're at a point where I think we can address this issue in a more systematic fashion. So would you be willing to work with a couple of our associate deans on this? We can and share the curriculum so we can see what works, because what we're doing clearly is not getting us the results we need.
Well, I'd love to say that Georgetown's numbers were better than yours, but they're not. So ours are improving, certainly, but I think we had much further to climb than where you are today. I think that you have much better resources in place already for your students to be able to shift the narrative. And, for us, it's taken a long time to get from that volunteerism space into the longitudinal partnership space. A long time. I mean, this has been 25 years of working on service learning, community-based learning, the Hoya Clinic, which is something that I stepped into about 8 years ago, our student-run free clinic. That's a whole nother lecture about student-run free clinics and what they mean to institutions and, the biases that they could introduce. But even our student-run free clinic, so difficult to walk into the room and disappoint a student who really wants to implement their project in the community that they haven't met before. You know, you don't want to disappoint somebody who wants to volunteer. You want them to be able to volunteer and see out, you know, this mission that they've set for themselves. I'm happy to work with any of the assistant deans here. I think it's a wonderful invitation. I do think that the things that we have experienced around our student-run free clinic have been helpful in reframing how we look at this. So like the navigator programs are now a much more students are participating in that than they are going to the student-run free clinic. So Hoya Clinic is an umbrella now of opportunity. Multiple things, from volunteerism to the longitudinal community partnerships. But if you want to engage in that longitudinal community engagement, you're a navigator. You're not necessarily going to the clinic for 1 hour. You know?
So thank you, Dr. Roett. One of the questions on the chat goes right along with what you were talking about as navigators. And their question is a navigator a coach between faculty and learner, or is this an extra pathway for learners along their journey?
That's a great question. So different systems define this in a different way, but most is in the health coaching space. So in our health system, we have navigators who are community health educators who are trained in health coaching. They could be a community health worker who has a certificate in being a community health worker, or they could be a community mental health worker. In the past, we used to call these roles care coordinators in our system. So when students came into this space and we wanted to choose what the name was going to be, the students wanted the navigator name. You know, we were thinking health coaches sounds really, you know, that sounds really nice, but the students liked the navigator title, so they went with it. And first started the refugee navigator program because at the time we had an influx of refugees, mainly from Afghanistan, into the area. And they really wanted to work with the International Rescue Committee, and that committee came to us and said, hey, this is our need, what could we do? And so that came out of that program. We have refugee navigators who are students. So in general, they're health coaches, but they're helping you navigate the health system as well. The training that they have now is a wide gamut. They're getting cultural humility training, anti-racism training, how to be a navigator. They're learning about the specific populations that they're serving. It's not part of our regular school curriculum. It's only part of being a navigator.
I know this might be like a naive question, but I'm a family doc. I've been a program director. I come from a refugee
Wonderful.
community. Like I love and bleed family medicine and primary care. And I find it like the big elephant in the room. And I'm just curious, out of all of this research and how we choose primary care, how much is, I find anecdotally that students have a hard time choosing primary care because of the financial implications to their life and the sort of the debt. And I know that it's kind of an elephant in the room, but I feel like it's a huge systematic issue. Oh, sorry.
Sorry? I heard something else. Oh, yeah. Yes, yes. Yep.
Yep.
Yeah, I mean, did you have more to your question?
Perspective and the answers students give for not choosing necessarily those primary care underserved areas, how impactful that is to that choice.
Sure. This is a conundrum. We talk about this all the time. I give quite a few presentations on, you know, what is family medicine, what is primary care, and introducing the specialties to pathway students, pipeline students, first-year medical students. And to be honest, they have no idea what the finances are. They're also getting that from us. They're also hearing from specialties that are not primary care that you shouldn't do this because you're not going to make the money. But to be honest, that's not really the landscape of how we get paid as physicians. I mean, the reality is the average salary for primary care physicians now is $255,000 with a range of $190,000 to $600,000. That's pretty broad. I don't think the average student gets that information. And to me, that's the piece of financial aid and, the admissions financial aid structure that we need to discuss. And then the average student has no idea about National Health Service Corps, about primary care loan repayment programs, about federal loan repayment structure, about the private organizations that now offer loan repayment to primary care docs. I think all of this information needs to be on the table to really allow a student to make that choice and make it based on finances. Because it's true, they are making the choice based on finances, but it's about not having all the information and not necessarily being informed about their picture. I mean, most of my colleagues, their student loans are already paid off because they've done loan repayment, they've done other things. So that's not the reality that students know, though. And then, of course, there's other ways like accelerated programs where you could, go from medical school in 3 years to residency and eliminate some of the debt from medical school. And then, of course, more scholarships to go to medical school if you're making a choice. We have a scholarship program now that's for students who choose this path of advancing health equity and committed to service, that they're getting some of their student debt eliminated. To me, you want to incentivize the student in that way so that they're not feeling as though this debt burden is along with my choice of serving the underserved. I should feel as though I'm valued by my institution for making that choice. Yep. Suppose that's a donor question too.
Oh, I have the mic, so I'm going to go next. This is Tina Younger, and I had a logistical question because you have 200 students per class, so 800 students, in medical school at any given time, and they're involved in a longitudinal project.
Mhm.
So, my question is, do they work in teams, and do you have like team leaders, and then they kind of string each other along and kind of weave in and out of the projects? Or are they all single?
Mhm.
800 different projects, I think you would overwhelm your entire
Oh,
system.
yeah.
So
Okay.
I'm thinking you
Yeah.
probably work in teams, and I just wondered if you could
Sure.
share a little bit about your infrastructure.
Sure. So all 800 students are not involved. The community-based learning course is for first and second year medical students, and now it really is only first year medical students doing it. So that's 200 students, and they're working in teams, and they're usually teams depending on the site that they're working with. It could be teams with 8 students up to 20 students. Mostly our elementary schools like to have more adults in the room, so usually they have larger groups to work with them. But in general, those teams are working. But every community partner doesn't want a longitudinal relationship with you. So sometimes the community partner just wants that. So it's an intentional process to determine which community partners want a longitudinal project that is beyond that year. So it's only a handful of programs that want a 4-year project or want 4 years of commitment with a student. So that's always been a very narrow list. The navigator programs are also like that too, because as a 3rd or 4th year medical student, you have a lot less time to be a navigator for your, we call them clients, but a navigator for your client. So the goal is that there's 2 navigators per client, that potentially one student is a 3rd year and one is a 1st year or something like that, so that when the 3rd year is busy, that the 1st year can take over. But the goal is for you to be with that client for the 4 years so that you could have that longitudinal experience, have the satisfaction around that, be able to experience some of the patient's ups and downs with them, or the client's ups and downs, and be supportive of them through their journey. Those aren't teams, and we haven't had any success with teams in that format. The navigators are usually individual or paired. We have a team structure of our navigators in that we support each other. We have a cohort, we meet regularly, we talk about the experience, the challenges, a lot of the heartbreak that clients are experiencing about, losing insurance or losing a loved one or losing a job. Students need a forum to talk about this, because we don't want them to feel as though they're alone in this work. And then we don't want their only experiences of it to be by themselves. So if they have support in this, they're much more likely to stick with it as well. So that team structure, I'd rather use that for support rather than necessarily overwhelming the partner with a team of students. So, and I also see community-based learning as a very separate category from what the community partners are looking for from us. So it's a course and it's fulfilling requirements of a course, but the other pieces of the community partnerships are not courses, are not required for all medical students. I hope that answered your question. Mhm. Sure. Mhm. Mhm.
So when you are crafting initial partnerships with community members,
Mhm.
what are your specific recommendations to create an environment where community members whose voices may have been historically unheard feel safe to express their priorities rather than just being like, oh, well, whatever you think is best?
Right. That's a hard one. It's about building the relationship and spending the time to build the trust. So sometimes for some partners, that could take a year, of establishing that relationship. So to me, that's why it's good to have some facilitated structure to this and so our Center for Health Equity, that's our focus. So we work with community partners who have been long-term partners of the institution. We have 30 partners. We have the Hillary Rodham Institute at Georgetown University has 127 partners. Our residency has another 10 partners. Everybody has partners. But our goal in this situation is if a student comes to us, because that's often what happens, is a student might come and say, hey, there's this organization that I happen to come across. Literally, we've had students who've been doulas and health coaches and so many things before they've come to medical school. I worked with this place before I came here. I really would love us to partner with. And that to me just starts the conversation. We could be having meetings for a year before we decide what we're going to do. And so that trust building is a huge part of the relationship. Sometimes I don't ask for anything. I just want to build the relationship and see, is there an opportunity that you're looking for that I could be helpful to you to find? And sometimes we have common ground about applying for a grant together. So I try to make it as organic as possible, just using best practices about how to approach it and let the community partner dictate, what it is that they'd like to prioritize. Mhm. It's hard to keep everybody in the room at bay though, because everybody's eager to say, let's just do it. Why are we waiting? And that is a balance that we've had to build with our Hoya Clinic in particular, because students come in with a lot of ideas of what they want to do. So I always say I'm the bad guy in this situation, and I'm okay with that. Of sometimes I have to be a little bit of the Debbie Downer of, I really love your idea. I think this could really work, but let's just talk a little bit about how we could make it work over time for maybe the next group of students, because we're not starting this tomorrow like you want to. It's going to take time.
Hi, I'm Maureen Tierney, and I chair the Department of Clinical Research and Public Health. And so that's both MD students and MPH students. And so community-based participatory research is something we're are already engaged in and increasingly engaged in. And there's very much the, as you sort of spoke about, the concept of trust is even greater, because if you're going to you do a study, it's got to be really be a partnership, and there has to be something that the community organization
Yep.
really has an understanding and is very much a part of the results and how things are working. Have you been able to, in some of the organizations you're partnering with in your setting, develop a community-based, research partnership with them as well?
Well, this is relatively new for us, for our center. It was not designed as a research center. It was designed as a research mentorship and facilitation center in terms of bringing people together who are doing the community-based participatory research. But in that journey of bringing people together, we realized, well, all of us are doing this. And so many of us are underfunded, and we have no way of moving our projects forward because there's no funding. So this last year, and this is how we got that P50 award, this last year, we designed smaller grants for community partners, where if they had a academic community partnership and somebody from our learning community, a learner, a faculty member, a resident, whoever was on it, that we could give them funding. So the funding is for the partner, and the partner's project. Some of the funding sometimes can fund some of the students' time, but it's intended for the partner. I think that's helped us to bring the partners to the table with the faculty they were already collaborating with. We're preferentially funding relationships that were already existing, not new relationships. But I don't think that we've come up with the formula to have community-based participatory research proliferate and have more people do it. This is really just supporting people who were already doing it, who were underfunded. So I would say the lessons we've learned have really helped us think about how to expand, and how now the P50, we've got to fund up to $100,000 projects instead of the $5,000 projects. But we haven't found a way to expand that to people who want to do it, who've never done it before. So perhaps we need advice from you about how to do that.
Michelle, thank you so much. I think so many of the questions here reflect the enthusiasm in the room for our moving in the right direction for better and more effective community engagement. I was reflecting on your talking about the students' enthusiasm in the Hoya Clinic for, I've got things I want to do. We as physicians and clinicians are trained to think of ourselves as the experts and the leaders in the room, and having the answers, diagnosing and giving the right treatment recommendations for our patients. Effective community engagement is almost flipping the script for that role in a way that unless we are intentional in how we're exposing our students to that part of their role in effective partnership with patients and with communities, they're not likely to see it otherwise. It's not a natural part of becoming a clinician in our traditional training modalities. I really appreciate Dr. Dunley's question, and several others sort of hinted at this, the opportunity for us to have an ongoing dialogue with you between Creighton and Georgetown, and learning together about how to get this right or move towards getting it right. I think there's plenty of opportunity for that. So let's give one more round of thanks to Dr. Roett.